Thanks. Thanks to Ed. Thanks to all of you. Thanks to the National Academies for bringing us together and SAMHSA for supporting this. I had this feeling in the conversation before that somehow I was channeling Gandhi's statement that if we want change, we have to become that change, and that we are kind of becoming that change in the world. So my journey here follows 25 years of trying to run state mental health systems. I'm not muted. And observing during that time that this was a persistent problem, suicide was a persistent problem. By my best guess, applying what we now know, about 3,500 people died of suicide in those care systems that I was responsible for over that period of time. So that's not very good. And the second thing I observed is that by and large, what at that time, going back 20 years, we were kind of being advised to do in suicide prevention seemed to me to be awfully distal from actually saving lives of people who were suicidal. And so it has put me on this quest, which leads to today and tomorrow. So we've already seen this. As a matter of fact, we've already seen a lot of this, which will allow me to move much more efficiently. But in Christine's data about levels of investment, we see part of the answer to this problem, which was trends in suicide don't look like trends in heart care or in cancer care or in stroke care for two reasons. One is if you want to make a difference, you have to do something. And we kind of haven't yet. The second thing is it would help if you do the right thing, which is one of the other focal points of the conversation today and tomorrow, to play out what would the right thing look like. A very different part of this exercise that I'll just mention, but I don't have time for depth on, would be to say, what is it that has actually reduced the rate of death from cardiovascular disease? And the answer is, while there's a fair amount of that by just reducing smoking, that's probably 25% of the reduction, and there's a little bit of it over here in interventional cardiology. Most of the reduction in cardiovascular disease is doing targeted preventive interventions with people with well-established risk. So, maybe we could do some of that. So there are several ways to think about, and we use all these mental models in thinking about zero suicide. It's partly, as Ed has said, a movement. It is a movement to secure suicide prevention as something that healthcare is responsible for, because now it ain't. The only requirement we have that really says people shall not die on your watch is with respect to inpatient care. And the Joint Commission Journal on Safety and Quality will publish in their next edition a comprehensive analysis of death rates in hospital, which conclude that of the 45,000 deaths we have by suicide, about 100 every year occur in hospitals. So that requirement, although important, because nobody should die when they're actually physically in our care, isn't touching the mission here. Just as there are no requirements around suicide in Medicare, there are no requirements for suicide in Medicaid. It has not been picked up yet by the healthcare enterprise. So movement is the first meaning. The second and third meanings sort of go to zero suicide as a care innovation. And Dr. Coffey has already spoken very well about the first of these. We should take it seriously as a quality improvement priority. I'm going to emphasize a little bit more of this other part. If we want to do something right, what is it that we have to do? And that's to talk about the care bundle, if you will, that is applicable for people with suicide risk. this is just a cover of that report that we came together at, David and Ed and I and Richard and some others. Suicide Care and System Framework was a report of this new Action Alliance. And essentially the way I think of this report was it was picking up the work that had been done at Henry Ford in perfect depression care and looking at its applicability to the larger healthcare system, with the advantage of a lot of time having passed since the work started at Henry Ford. This was like a decade later, and it turns out that, and you can see this if you were looking at Dr. Moutier's slides, almost all the stuff that really is new all the stuff that's important is new. So we have a lot of evidence now that wasn't present when the team at Henry Ford started this work. One of the things that I won't dwell on has to do with somebody who's tried to run systems for a long time. It's nice to have data on what's effective, but most of what you have to do, there's no data on. So it helps to have a theory. It helps to have a relevant theory. And we're starting to develop a lot with respect to what I would describe as grounded or relevant theory about suicide. And I want to sort of focus in particular on this one little study that I think is nicely illustrative of how to think about suicide risk. And it's this study by Alex Milner et al. And it's a very small study. So very detailed interviews with about 36 people in hospital after an attempt. And the idea in the study was to trace with them through a very careful, grounded interview what happened with them from first ideation, first thinking about suicide, to this serious attempt. And I got 3 things out of the study. First thing was, for the average person, it was 2 years between ideation and attempt. That's a lot of time to do something, but only if we know. And since we tend to not ask, we don't know. So we have a lot of time to do something. Second thing is, once people had reached a tipping point in their own process, the time from that to the attempt was short. In this study, it was 2 weeks, but it was a range of minutes in some cases to a few weeks for other people. That's like a little late to get to that point. And the third thing, which is a cautionary tale, is there was no consistent pathway. Human beings are complicated, life is complicated, genetics are complicated, genetic environmental interactions are complicated, systems are different anyway. So having this is pretty important. One of the things that emerges from this new theory is lots of people, as has already been said, walk around with thoughts of suicide, but only a tiny fraction of them act on it. And one of the things that becomes really critical is, as Thomas Joyner describes, achieving the capability, both the internal capability and the physical capability, is something that for most people is hard, giving us, again, time to intervene if we grab that opportunity. So one of the thoughts, that I guess one of the questions or one of the propositions is why suicide prevention in healthcare, and there are essentially 2 reasons for this. People are dying in our care is the first reason. 80% of those who die and over 90% of those who make an attempt have had a recent visit. So, do you think we could, try to do something about it? And that goes to the second point, which is, in thinking about suicide, population-based data is intriguing. It's hard to reach populations. You have to have a fulcrum in order to use a lever, and healthcare settings are settings in which people are seen, and therefore we have a lever. We have a place to do something that we can reach them. That's kind of hard to do if we're thinking about old men. Kind of hard to reach. What's the one place to go to reach old men? So it's a problem in healthcare. This slide is kind of my mental model of the cracks that people slip through to die by suicide, overlaid by the things on which we now have evidence to act. And I'll click through this very quickly and then do the evidence sort of even quicker. If we go back to the previous slide, where 45% of the people that die by suicide had a recent PCP visit. Yates Conwell says among older men, that's north of 70%. So just 70% of old men who end up dying by suicide in the next month go to see a GP. Is that random? It's not random. Do they have pain of some kind? Yes. Do we have the tools as ordinary human beings to deal with that pain? No. Who do we go to see? The health professional that we trust. What doesn't happen? We don't ask. And then there's a death. So not asking is the first gap that people fall through. Then of course, there's if we ask and people say, yes, I'm really troubled by that, do we do the right thing? The first right thing is essentially a safety planning intervention, not as a piece of paper, but as an intervention to begin to give people a skill set and tools to manage all this. So, with Justin's permission, I'll mention that he and Ed's relative who had the stroke, it was a pretty serious stroke. And she got to the hospital very soon and got a TPA very fast. That's what the evidence indicates with respect to stroke. The evidence with respect to suicide prevention is not a drug. It is an interpersonal, supportive, structured communication. That's what the evidence is, and this is where that begins. Taking steps to reduce lethal means, this radical idea of directly treating suicidality, which is fundamentally relevant to this workshop. And I think we've already maybe begun to establish the point that if somebody is suicidal and has a major mental illness, it's no longer acceptable to just treat the major mental illness and hope that the suicidality resolves. We can't expect results for this by doing this, even if they're related and even if this is likely to help. And finally, the incredible power of support, interpersonal support. So a different way of thinking about zero suicide than a slogan, than a movement, is to say it is these actions which need to be done in a routine way within a healthcare setting. It's a care pathway. And not doing this would be kind of the equivalent of having people in care for diabetes and never getting an A1C level. Like hope is like really powerful for people, but hope that people will change is not very relevant as a strategy. We actually have to do some structured things. So this point again that we usually have a lot of time to intervene. This is the study that I think Christine already referred to. So this was 75,000 plus people who had completed a PHQ-9, going back 24 months later and looking at who actually died by suicide. And of those who died by suicide, what did they say on the PHQ-9, particularly question 9, which is the suicide question? Over 60% of the people who later died by suicide had indicated when they were asked elevated thoughts of suicide. Now, we've had this stupid debate in the suicide field about we can't predict who's going to die. We shouldn't be interested in predicting who's going to die. We should want to know who needs a little help. And cardiologists are not, worried about, we can't predict when people are going to die of a heart attack and who that's going to be. They identify risk factors and then they take action and then they move on. And it turns out that this 60% predictive value, not of who's going to die, but predictive value of who's going to use help, is twice as good as cholesterol is as a predictor of who's going to die by a heart attack. And we sold, $29 billion in statins last year. So this is good enough evidence to act on. Safety planning. That safety planning is so common sense that it's become widely used, but until recently, with respect to Craig Bryan's study, which is only out a couple of years ago, we didn't really have great data. So this is the Stanley Brown et al. Report just out in JAMA Psychiatry. It uses safety planning plus supportive, structured contacts, which reduced suicidal behavior by 40%, and interestingly also doubled the percentage of people who who got engaged in care, which is also a good thing. Means restriction is a critical part of the safety plan. It also, from conversations with Ed and Justin, was a foundational part of Henry Ford's efforts. If somebody was thinking about this, to work in a concerted way with them and with their family to try to identify those means and to create some distance or to remove the means if it was possible. We have overwhelming evidence about this on population-based studies, where in every circumstance that's been studied where there's a dominant means of suicide in a particular community and you restrict that means, the rates go down by about 40%. So that, we can do that as well. Overwhelming evidence of the effectiveness of carrying contacts. I don't think, Michael, that you were actually the lead author on this study, but it was you were one of them, and it was a great recent study that looks at the cost effectiveness, essentially, of carrying interventions. And these are the cost intervention of carrying letters, phone calls, and CBT are sort of way better than the usual standard for putting an intervention in place in our healthcare system and used way less. So we have work to do. Directly treating suicidality, that's been well covered. Again, these interventions are about as good as acute treatment for cardiovascular disease. Like, we think we're ashamed of ourselves, but we're actually pretty good. And so a little bit about the evidence for this bundled approach, sort of overall. I mean, the first critical point to understand is the usual care for people at risk of suicide is horrible. People are dying. It is unacceptable, the way it's happening right now. Ed showed the Henry Ford data. The Centerstone and Institute for Family Health data isn't published yet. Both these places, Centerstone is a community mental health organization. Institute for Family Health is a comprehensive healthcare organization. They've achieved reductions from baseline of 60 to 80%, with ups and downs, because this is a complicated problem and it's a low incidence problem, has been described. So it looks like if you do the right stuff systematically, the outcomes improve. A separate point is that the zero suicide as a package is made up of elements, each of which we know to be effective. So it makes sense that the overall package would work because the elements work if they're done with fidelity. This is, sort of kind of arcane and in the weeds, but a part of the zero suicide package or model is this organizational assessment, which is also a fidelity tool. And an interesting little study done in New York with something like 200 clinics that are implementing this, and they all did this baseline study. And then what they did was to take all the clinics that had had a suicide death in the prior 6 months and those that hadn't, and compared their baseline results on the fidelity score. Places that are doing better suicide care had less suicides. So this makes sense as well. But we really do need more data to get the late adopters off the schneid. I won't spend time on this. All the tools to do this work are on this zerosuicide.com website, except leadership and elbow grease. And it turns out that leadership and elbow grease are pretty important in getting stuff done. How are we doing in implementing all this? The really big problem is getting healthcare to say it's our responsibility to keep our patients alive. And I would say if we look at the old adoption curve that goes like this, in behavioral health settings, we're kind of here. We're starting to get up the adoption curve, but we're pretty down here. In primary care, in emergency departments, in healthcare systems, we are just at the beginning. The Joint Commission's Sentinel Event Alert helps. CARF's improved standards help somewhat. We have a lot of work to do. This is the Joint Commission's alert. And so this is concluding thoughts from me about the point of this two-day workshop. And the first fundamental point is that intense suicide risk is linked to but is distinct from other mental disorders. And this point that I want to hammer about, yes, intervening with the depression or the bipolar disorder is important. It is not sufficient. Second, we have a lot of experience in, like, if for example, treating co-occurring mental health and addiction problems. And we know several things don't work. Ignoring one of them doesn't work. And trying to fix one and hope that after you fix that one, you fix this one, that doesn't work. And the only thing that works is integrating the two of them in a thoughtful way, which is what the evidence here really suggests. So treating the mental disorder alone is essential for relief of that pain. But there are now established interventions for suicide care, and we have to integrate those into the work of every mental health practitioner and setting. Then we'll go on to primary care and emergency departments and so on. And this point, going back to the cheese slide again, is that key to this work is establishing a care pathway, so it's predictable and can be measured. Thank you so much. David Covington will talk about how we're doing on this nationally and internationally and the efforts we're making to advance that.